welcome, and I hope this rather brief presentation will get you thinking about first provide information about what we do, a part of what we do at the Alzheimer's Disease Research Center, and then perhaps have you thinking about how you might be able to help and participate in some of our studies. So I'm going to talk in the next 10 minutes about a number of topics related to the studies. One is new ways in which we think about Alzheimer's disease and Alzheimer's pathology, which is different than what Dr. Chu had mentioned. We came up in the 1980s. In the 1980s, we thought about Alzheimer's disease differently than previously. We thought we were on. There was a new way of thinking about it. And now in the 2000s, there's yet another way to think about it. Then I'll speak very briefly about amyloid antibodies as a therapeutic, and there I'll talk about our A4 trial and hope to give you an appreciation of how these trials are designed and carried out. And if we have time, I'll then further talk about what the future might hold. So, how we think about Alzheimer's disease and drugs. This has changed over the years, but to a large extent now, we think about Alzheimer's disease as a pathobiological entity that over time and way before symptoms occur, proteins and protein fragments, A beta 42, and collections of amyloid fragments aggregate due to reasons we don't understand, due to maybe too much production or decreased clearance or other factors. And the aggregates, the amyloid aggregates, can either aggregate further into plaques, and I think you've all heard about the amyloid plaques being a key feature of Alzheimer's disease, and they exist outside of neurons, between neurons, or the abnormal amyloid can aggregate into smaller groupings, into little groups of 12, of 4, of 6, of 20 oligomers, and those are soluble amyloids, and they also are between neurons and thought to be pathologic or harmful in the way they interact with receptors and other cells. And we think that causes a immunologic and inflammatory response, which then is damaging to neurons and ultimately leads to death of cells and to cognitive impairment. So it's with that kind of thinking that we think about drugs and therapeutics, and we think about a drug that can attack this process or alter this process. It's also with this kind of thinking that we reconceptualize Alzheimer's disease into stages such as being at risk or having preclinical Alzheimer's disease, because we see that we have plaques but no cognitive impairment, or we see that we have an abnormal biomarker such as the amyloids that I was talking about, or another protein called tau. And the abnormal biomarker itself makes us think that a person has Alzheimer's disease before clinical symptoms, preclinical. We also think of prodromal Alzheimer's disease or mild cognitive impairment, where somebody has amyloid, a positive amyloid biomarker, a positive PET scan, but also unfortunately has memory impairment and cognitive impairment, but not to the degree that they have dementia, that they have impairments in activities of daily living. The reason that prodromal Alzheimer's disease is so important is because this is the group of people who have been treated with antibodies and other drugs recently. And this is the group of people on whom an antibody you might have heard about, aducanumab or Aduhelm, was tested and controversially approved. But what I'm going to talk about is the preclinical Alzheimer's disease, where we're able to observe the increase in biomarkers in the amyloids and an increase in the tau protein, excuse me, and some reduction, some changes in MRI, in brain volumes, before cognitive impairment actually starts. So I described this. I should have actually moved my slides. I just described this, that we can think of going through stages of Alzheimer's disease from being not impaired and having no positive biomarker to preclinical Alzheimer's disease, where we're still not impaired. We may have some memory complaints, but now we have a positive PET scan, to going to prodromal Alzheimer's disease or mild cognitive impairment, where we can see where we have some difficulty with memory, some difficulty remembering stories, for example, but otherwise we don't have major difficulties with our regular activities of daily life. And we have a positive amyloid PET scan. So these are the areas that we focus on in medication treatment. So now I'll move to current to our current studies and towards the A4 study. I had mentioned before that aducanumab, Aduhelm, and a number of other amyloid antibodies are tested and are being tested as we speak in prodromal Alzheimer's disease or mild Alzheimer's disease. And in October, we're going to learn the results of studies of some of these antibodies that are, again, very similar to Aduhelm. In these studies, which we call secondary prevention studies, people have symptoms and a positive biomarker, and they are treated with an antibody for 18 months to 2 years, usually given once a month, and usually the antibodies are given intravenously. And it's over this 18-month period where people are randomized to medication or drug that we're able to determine whether there's an effect on cognition or on global function due to the antibodies. And I had emphasized amyloid before because our current drugs are antibodies that are designed to attack the amyloid plaques, which are between neurons and are really rather big. So these antibodies, with one exception, are designed to essentially bust up and destroy this plaque. This is another microscopic view of the plaque, and you can almost imagine how I hope you can see my pointer, how an antibody might come here and grab onto these pieces of amyloid and essentially remove them. So it'll be very interesting. In October, the results of two other studies, two other drugs or antibodies, to see if they confirm or support really any evidence that Aduhelm worked. Okay, now primary prevention, and this is about our A4 study. As I mentioned before, here we're talking about people who have preclinical Alzheimer's disease, no cognitive impairment, but a positive biomarker. People who otherwise qualify, otherwise are concerned about their memory or would like to help in understanding our options in preventing Alzheimer's disease can volunteer for these studies. These trials go on longer than 1.5 years to 2 months. They go on for 4 to 5 years, and they're often large. They often involve 1,000 to 3,300 participants. And over this time, we're measuring whether there is change in memory or whether the intervention might delay or stop the onset of further memory impairment or actual functional impairment, which we call dementia. There are at least 5 of these types of prevention trials. The A4 trial with solanezumab, which I'll talk about on the next slide. The AHEAD 345, which is another prevention study in preclinical Alzheimer's disease that we are doing nationally with the antibody lecanemab. There's Trailblazer with another antibody, donanemab Skyline with another, and a study of autosomal dominant early familial Alzheimer's disease. Dr. John Ringman here works with this with the group of inherited Alzheimer's disease. With lecanemab. These studies are designed to try to prevent the onset of cognitive impairment and to lessen or stop the progression of the pathology. So the A4 study is something we've been working on for about the last 7 years. And here at USC, we recruited originally about 30 to 33 people with preclinical Alzheimer's disease who were, we still don't know, were randomized to placebo or to solanezumab. They received solanezumab monthly. They visit us monthly, and in our infusion clinics, they receive an IV that takes about a half hour to infuse the antibody. So you can imagine how over these 7 years or so, our team, Mauricio Becerra, Liberty Teodora, and others have worked and learned about our participants. And this is how a study like this goes. Clinical inclusion criteria are many mental states in the almost normal range, an age requirement between about 65 and 85. We test to make sure that people's ability to remember a story is pretty good, is above impaired. And again, we make sure that they have an amyloid PET scan. And here in this diagram, you could see what we and about 30 other sites across the country had done. We screened 10,000 patients, 10,000 interested people. We screened 5,000 in clinic. We got PET scans on about 3,300 people, and about 1,100 were, a little bit less than 1,100 were ultimately qualified to be randomized to solanezumab or to placebo, and then to be followed and treated monthly over the course of, actually it's longer than this, it's 200 and some weeks, nearly four years or longer. And our patients received at the beginning a smaller dose of solanezumab, 400 milligrams. And it was during the study we realized that we needed to actually increase the dose to a much higher level, which is imperceptible to the people receiving it. It's just the same, it's really the same IV. And so this is what these kinds of studies are like. Now, I will say that solanezumab is a somewhat different antibody than the antibodies I just spoke to that attacked plaques, because solanezumab doesn't attack the plaques, but they attack the small soluble amyloids. So as I'm describing this, I think you can see that there's subtlety in our considerations for treatment and in the medications we're using. So we are currently working on a study similar to the A4 study called the AHEAD 345 study, which uses lecanemab, which is an antibody that attacks and reduces plaques. And here it's very much a similar kind of trial, except we're now looking at just how positive an amyloid plaque, how an amyloid PET scan is. Does a person without symptoms have a lot of amyloid or a relatively little amount of still abnormal amyloid? And what we're testing in these two different groups, an A3 group and an A45 group, a group with a little amyloid, a group with more amyloid, is whether lecanemab might be separately effective when there is a little amyloid or whether it's effective when there's more amyloid, because this would tell us just how early we need to go to treat. So this is our study that is replacing the A4 study that I just mentioned. We'll finally learn about the effects of A4 in about January, coming up, January or February, and that will also be a big event in Alzheimer's therapeutics. So in October, we'll learn about two antibodies in mild cognitive impairment or prodromal Alzheimer's disease, people with symptoms. And in January, we'll learn about solanezumab in preclinical Alzheimer's disease, or people without symptoms and who are amyloid positive. So this is what we have to look forward to in the future of therapeutics. We're increasingly using biomarkers to help diagnose and to predict treatment and predict type of treatment. We're doing longer-term prevention trials. We're using treatments that are specific against the proteins, the abnormal proteins in Alzheimer's disease. And this is what we're doing on the drug research end. On the other hand, in our clinical practice and in our clinical research practice, we're actually doing more in terms of risk reduction, of identifying people with established modifiable risk factors, such as vascular disease and hypertension, vascular disease, hearing loss, and other risk factors such as physical activity and diabetes to try to reduce and modify those risks. So anyway, I wanted to spend a bit more time than I was allotted, I think, to try to give an appreciation and a depth of our studies and what we think about when we're designing them and carrying them out, and what we hope to find. So thank you for listening.